Tonight, I'm absolutely delighted that we've got Ollie Hart speaking. So I'm going to shut up and hand over to Ollie and let him take us take us away. Thank you, Ollie.
Oh, great. Thanks, Caroline. And it's lovely so many of you giving up your time of an evening. So hopefully we won't let you down. We're planning to go for about an hour, but I think it's not a hard stop, so we can carry on chatting if we want to, or give up the ghost in an hour. I'm planning to share some slides with you and do a little bit of sort of background, and then we'll have plenty of time for discussion, I hope. So let me just share some slides. So I've called tonight Rethinking Persistent Pain because I do think this is about rethinking how we work as professionals, but also kind of almost slightly re-evaluating our relationship with pain. I'm a GP from Sheffield. I've also been a clinical director of a primary care network in Sheffield for the last 5 years since they started, and I've always had an interest in pain management. I started my doctoring career as an anaesthetist, working in the pain clinic, and then became a GP with special interest in chronic pain. Probably 15 years ago now. It's always been close to my heart. I'm also a clinical director of peak health coaching, and I'll tell you a little bit more about that as we go along. So I always think it's really important, though, you know where someone's come from and what their conflicts and so on are. And certainly when it comes to this topic, I've learned loads from other people. So what I'm hoping to bring to alive tonight is a combination of things I've learned from my own experience as a GP, with special interest, but also through colleagues like Tim Williams, Deepak Ravindranant, Kathy Stannard, Professor Anne Taylor when we were working at the British Pain Society, Francis Cole, Chris Barker on the GP, but also particularly in the last 2 or 3 years, loads I've learned from expert patients, people with lived experience. I knew a lot, but people like Lee, and it's great. We've got Lee on the call tonight, Narinda, Sean, loads of people around the country who I've networked mostly through Lee's contacts actually, and learnt so much. That's been a really enhanced my understanding. And so pioneering groups across the country, the Flipping Pain team, the Living Well with Pain team, Francis Cole's group, the Pure Physiotherapy team, the Cornish Pain Cafes. There's just so much innovation going on in this area. I did say I'm a director of peak health coaching, and we do sell pain courses. So, I do have a conflict of interest in here to some degree. I guess the only reason I stepped out primarily out of general practice to do this is because I really believe in it. And it's probably not as lucrative as being a GP. So I don't feel too bad about it. I'm doing what I really believe in. And in the past, I've been paid by just about every drug company under the sun related to pain management, but not anything in the last 7 or 8 years, I would have thought. And you'll probably understand why as we go through this. So that's what's coming up. I thought I'd do a little bit about why we should focus in on this, a little bit about where we've come from, what's the current, most contemporary understanding about pain management, and then a little bit of thought about where we're going and how lifestyle medicine can really support great pain management. So hopefully it'll be useful to you. But of course, with all these things, it's not really about what I know, it's about what you get out of it. It's a coaching principle I'm really guided by. So what I hope tonight will just stimulate thinking and ideas for you to either put into practice or take forward yourselves. So why should we think about chronic pain? I'm sure you probably know this. Anyone that practices in healthcare realizes that chronic pain is everywhere. But this is a really interesting slide from a sort of research that was coordinated by the Health Foundation. And this is what they anticipate will be the main distribution of chronic diseases in 2040, with chronic pain being by far the biggest, most common chronic disease, more than diabetes, more than mental health. And in actual fact, what this says in 2040 just really extrapolates from where we are now. Chronic pain is at the moment the most chronic long-term condition, with 5 million people in this country living with it, projected to go to 7 million. So it's really common. And when we think about chronic pain, it's worth sort of thinking about who has it. So they say 1 in 3 people live with some sort of pain every day. So it's a persistent part of 1 in 3 people's life. However, what we should really think about is that of those 3, 1 in 3 of those have what we call high impact chronic pain. And the definition of high impact chronic pain is that it's at such a level that it causes significant impact on your life. So you have to change your lifestyle and what you do day to day because of pain. And that's 12% of the population, 1 in 8 people. And when we look at that overall pain of 1 in 3, you can see it gets more common as we get older. A little bit more of a leaning towards women than men, as you can see from this one here. But even when we look at the younger groups of people, 13% of men aged 16 to 34 and 22% of women aged 16 to 34 live with persistent pain. It affects people in employment and it keeps people out of employment. And the most common sites tend to be the back, the shoulders, the pain, the neck, I guess, in the limbs. But there are, of course, other organ pains as well. But so it's really common and it has a massive impact on society. And when we think about pain, I really like the flipping pain messages and I'm going to sort of talk around them a bit tonight, I guess, really. And what flipping pain did was that they spent quite a lot of money actually talking to people who live with pain and talking to kind of marketeers and advertisers about what are the key messages that we probably need to get across. And I thought I'd early on just flick those up. So just as I've said, we've got to acknowledge that persistent pain is really common and it can affect anyone. It's not your fault if you end up with it. You shouldn't be to blame. You're not weak or stupid. It's just really super common. A key message to get across is that hurt doesn't always mean harm. And I'm going to come to that a bit later on. We're traditionally conditioned from a young age to think that when we get pain, it means there's damage, but hurt doesn't always mean harm. Everything matters when it comes to pain. There's a whole lot more that contributes to it than tissue damage. And again, we'll come to that. Medicines and surgeries are often not the answer. It's a really interesting one, isn't it? Sometimes they are, but often they're not. Understanding your pain can actually be really key. And again, we'll talk a bit about that. And the last one, which often causes a bit of raised eyebrows, particularly people who've lived with chronic pain for many decades, recovery is possible. And actually, for me, as someone who's worked in this field for a long time, I feel this is where we've got a new sense of optimism and hope in this area. Because I think that the new things we've learned and the new techniques has really made recovery much more viable than it ever was. But of course, recovery will mean different things to different people. And as we'll come to, we all need pain. Pain is a very important part of life. So recovery doesn't mean no pain at all ever in your life. So we just keep that in mind. So I thought it would be good just to think about where we've come from. And to be honest with you, part of the reason I've got such a passion in thinking about chronic pain management is I think actually I've been part of some of the problems that have beset pain management previously. So a couple of things really. We all start off really from the acute pain paradigm. Most of us learn pain as a marker of an injury. We stub our toe, we fall over in the playground, we cut our lip, and we get pain as a marker of an injury or tissue damage. And that's how we learn about pain. But of course, most of the experience of pain, most of those 1 in 8 people are not living with acute pain. They're living with persistent or chronic pain. And we have to rethink our definition on what's going on there. Within that, I think chronic pain has suffered with a sort of like the explosion of modern medicine, and it's led to this blind faith in medical professions as the kind of the experts in pain, that we just got to sit back, listen to them, they know what they're doing. And I think that's caused us a lot of problems. And one of the things I've been really a part of in working in the pain clinics over my career is that back in the early 2000s, there was this big drive that the kind of, good pain relief was a human right. And it's really interesting. When I look at this quote here, I was looking back, just researching for this, thinking about, when did that all start? And I actually sat on the British Pain Society's council, the board, back in this time. And I remember at the time this is one of the papers that was put out, and on the Global Pain Day in October 2011, 2004, the International Association for the Study of Pain and EFIC, I can't remember what EFIC stands for now, the European version, together with the World Health Organization, declared that pain relief should be a universal human right. Incidentally, that paper was at the end of that initial summary, there was this group is indebted to Nat Pharmaceuticals for their generous sponsorship of this meeting. And I'll leave you to draw the conclusions there. So this kind of concept that analgesia was a human right, and if we weren't doing it as doctors, we were depriving people of their human right, I don't think has helped us a great deal. And it led to us kind of like having interventions. And the narrative here was that, well, if we do something, we prescribe a medicine, we give an injection, we'll break the cycle of pain, and that will allow people to settle down. And we very much came from the school of actually we ought to give a background pain relief, whether that's a slow release opiate, and that's what we should do. And as you'll see through this, that was really not the right way to go about it. But I hold my hands up and say, really sorry, I was one of the doctors that was right in the centre of this, which is sort of why I feel a bit of an obligation to try and unpick it. On this background as well, so bring us up to where we are now then. So the latest NICE guidance came out in 2021 for chronic primary persistent pain. And what they say, unfortunately, is that there's no medical intervention, pharmacological or non-pharmacological, that's helpful for more than a minority of people with chronic pain. And the benefit treatments are modest at best and effect in terms of effect size and duration. So really, they're saying when they've studied it closely, none of the tools we had is really that useful for many people. And even worse than that, they acknowledge that actually, GPs and non-chronic pain specialists find pain management really challenging, and they often have quite negative perceptions of people with pain. So often, we would think of these people as like, oh, they're sort of heart sink patients. Oh, what am I going to do? They keep coming back. I've tried all the things I know. Nothing seems to be working. What am I going to do? So it is a little bit of a conundrum, isn't it? So on the back of that, as well, when they go on to say medicines, so all the things that we've traditionally used, opioids, paracetamol, non-steroidal anti-inflammatories, trigger point injections, ketamine infusions, benzodiazepines, topical treatments are all out. NICE guidance says we should avoid them. In terms of medicines, and I'll come back to this a little bit later, there is a place perhaps for some of the antidepressants to perhaps modulate some of the central sensitization. And there is probably a place if you've got neuropathic pain, so if you've got pain from damaged nerves, either centrally or peripherally, then again, some of the anti-epileptics and some of the antidepressants can be useful. But they play a small part and only really in a sort of specific subset. So, we're in this real dilemma, aren't we? The tools that we had just don't work. So I'm going to come to this idea that actually understanding your pain and knowing what pain is for is really helpful. And I'm going to sort of play out a narrative that we found at Peak Health Coaching to be quite helpful, really, both from how professionals work and how patients think about it. So the concept is that the brain tries to protect us, and that pain is actually a protective mechanism. So it's a really helpful thing for us. In fact, without the protection of knowing about pain, we'd be in real trouble, actually, as we might discuss further. But what the brain does is it basically has to sense inputs. So it has biological inputs, nerve signals coming in, which tells us when there's tissue damage or when something's stabbing us or burning us. But it also has to interpret signals that come from the psychological aspects of the brain. So our memories, or our mood, or our sense of anxiety or sense of nervousness. And it also receives inputs about our social situation. So whether we feel threat, whether we feel we're in a situation where we're under threat. And basically the brain has to make sense of these biological, psychological, and social inputs. And it decides, the brain has to make a decision. Do I need to make pain here to protect my human? And pain is made in the brain. Let's not dilly-dally around that. When people say pain is all in your head, it is all constructed in your head. But that's very different to saying you're making it up. But nevertheless, pain is made in the brain. Without a brain, we don't have pain. So it creates pain, and it does it out of benevolence for us, to try and look after us, to protect us, get us away from a threatening social situation, to react to biological signals to protect us, to help learn from memories we've had in the past to try and protect us. And if you like, what pain's actually trying to do is it is actually trying to keep us safe. Of course, what happens if your brain gets locked into an overprotective mode? Oh, sorry, let's go back. If the brain's in an overprotective mode, which we know is really what happens in persistent or chronic pain, where the brain, if you like, becomes oversensitive, you then end up, instead of useful pain, of having really unhelpful pain. And in response to this overprotective brain, the body tends to then tighten up, and you get a kind of overprotective body as well, which, enhances the pain. And we get stuck in what we often call these pain cycles, don't we? So, I'm looking at Lee here. I can see your picture. Pete Moore has his lovely pain cycle, but we actually prefer this one, Lee, don't we, when we do teaching together, because it kind of divides out. You get this sort of physical vicious cycle of because of pain, you stop doing things, you decondition, your joints and your muscles get weaker and stiffer, and then you get sort of further tension and further pain. So you get that physical vicious cycle, but you also get that psychological vicious cycle where because of pain, which is horrible. It makes you miserable and depressed. It makes you feel, your world's closing in, your mood gets lower. And that feeds anxiety, fear, distress, which feeds pain even more through the psychological pathways. So it's not surprising once pain set in, it kind of often it's a beast that feeds itself. And these concepts can be really hard to explain, can't they? So actually, I think some of these kind of like metaphors to explain pain can be really useful. And I think part of our role we can do is to take our time to help people understand what's going on. And I really like the car alarm metaphor. And when I'm thinking about metaphors, it's funny really because I think we often use mechanical things to describe pain, but and they can be useful. But of course, we are emotional beings as well. So although these describe perhaps some of the mechanisms, they perhaps don't capture all the emotions. But the concept behind the car alarm metaphor is that you have an alarm on your car to warn you when someone's breaking in. So you've got your car there, someone's smashed the window, broken and taken your handbag off the front seat, and unfortunately the robbers got away with your bag and they've stolen your bag, and you're really cross and peed off. So you take your car back to the garage to get the window repaired, pay your money, and whilst you're there, you say, "Do you know what? It's so annoying. Do you think you could turn up the sensitivity on my car alarm? Because I don't want this to happen again." And the garage man says, "Of course I can. That's what I'm here for. That was what makes me useful." So the garage man turns up the alarm. So the car alarm's more sensitive. Then, of course, you take your car home with this very sensitive alarm. It's parked in the driveway, and 3 o'clock in the morning, the car alarm goes off, and you think, "Oh, someone's breaking into my car." And you rush to the window and look out, and there isn't anyone breaking into your car. It's just a fox that's brushed past your car in the night, or maybe a brush of the wind. And actually, that alarm now isn't warning you of anything useful. In fact, it's been really annoying. It's got you out of bed, it's woken you up, and you can't get back to sleep. And that's a little bit like what's happening with our pain system, is that for whatever reason, and we'll come to that in a minute, our pain system's got more sensitive. And instead of giving us good warning signals, it's not warning us very well. Another one that I know Lee likes, which I really like as well, is that, again, a bit like the car, it's a bit like the reversing parking sensors. We have those parking sensors to warn us when we're reversing that we might be about to hit a car or a wall behind us. And we want those sensors to give us warning in advance, don't we? Because we don't actually want to hit the car or hit the wall. So we have this kind of warning system that tells us. But of course, we don't want it to be so loud that just listening to it is really painful. And we don't want those warning sensors to go off when we're 20 meters away from the wall or the car. We want it to be just tuned in just right. And that's what seems to happen with chronic pain, is that for whatever reason, our pain system has become oversensitive and it's no longer useful to us. And I guess the underpinning message behind this is that what pain's actually doing is it's kind of desperately trying to protect us, but actually what it's not doing is giving us a good, reliable indicator of tissue damage and harm. It's going off sort of when it doesn't really need to. So the pain, the hurt, it doesn't really mean harm. And I think this is such a crucial thing to get into our heads as clinicians, but also to help our patients to understand as well. So with that understanding, where do we go from here? What can be our role with this new understanding of pain, where acute pain, tissue damage pain is just a subset of pain, really? It's one of the markers of why our system is protective. But actually, what's much wider is this kind of like, if you're oversensitive of the pain system, where do we go from here? How can we use this information to how we support people? And I'm going to talk about three things. Who's in control? That seems to be so crucial. It's so important that we move from being the people that are helping people to manage pain to helping people to be in control themselves. And in doing that, I think the two things, again, I've learned with Lee and colleagues, is finding evidence that fits for the person, that shows that their pain system is being overprotective, and then discovering what they can do that works for them to help down regulate it and let the brain, if you like, take the brakes off. So I don't know if anybody knows who this chap is. I'd be really surprised if you do, but some of you may have heard his name during this sort of group. Anyone know who he is? No. Okay. Some of you might have come across his theory. So he was the author of something called salatogenesis. His name's Aaron Antonovsky. And what I really like about he had a huge body of research. He's got quite a sort of like a cult following to some degrees, actually. He sort of died in quite mysterious circumstances. No one quite knows what happened to him. But what his research did in the 1940s and 50s was really shone a light on what it is that it helps keep us healthy. Salatogenesis is a term that it's almost like the opposite of pathogenesis. So pathogenesis is what makes us unwell. Salatogenesis is what makes us well. And his research and lots of research subsequently has shown that actually the thing that keeps us, the strongest indicator that keeps us well is what he called this sense of coherence. So what he defines as kind of how much sense life makes to us and how manageable and meaningful that life is to us. So this kind of idea of our sort of, locus of control, us being in charge and our life being meaning for us is actually one of the main determinants of whether or not we're well, whether we thrive and live pain-free and a good life. And I think that's really interesting when we think about this kind of control factor. And I'm minded of another story. When I was in the pain clinic, there was a pain consultant called Charles Moore, and he was um, coming to the end of his consultant years. And you know those wise people that always have stories up their sleeve. And he used to say to me, you know what, Ollie, the thing about pain management is you have to help people regain control. He said, living with chronic pain is like owning a Rottweiler. He says you've got that Rottweiler. Whatever happens, you've got that Rottweiler. But there's two types of Rottweiler owners. There's the first type where the Rottweiler's dragging you along and it's dominating everything you do, and you can see this guy here, he can't keep control of it, and you're really at the mercy of that Rottweiler. I don't think this dog is a Rottweiler, but you get what I mean. The other type of owner is someone who's got a tight leash. They've still got this kind of like difficult, aggressive Rottweiler, but they've got real good control over it. They've got a tight leash and they keep it leashed in. So the locus of control seems to be really important when it comes to pain management. And we'll come back to that a little bit in a second. So the other bit I want to come to is around sort of helping people to find their own evidence. And we know again from lots of more recent research, this is particularly taken from a book by Alan Gordon, who's done a lot of research with Howard Schubiner in the States. And their research has shown us that there are proactive ways that we can diagnose an overprotective brain. There are certain things we can pick up on. We know that if people describe a story of their pain coming on during a time of stress, or there was minimal injury, it's much more likely to have come from an overprotective brain rather than perhaps something we might be really worried about missing, like a cancer or an inflammatory disease or something. We also know that signs of an overprotective brain are that you can have large volumes of symptoms that can change and spread. Those symptoms are often triggered by unusual things like stress, but also like sounds, like smells, like feelings. And I'll give a little story for that just before I finish. And often pain from an overprotective brain is delayed. You perhaps don't feel it when you're doing something, but you feel it afterwards. And we know that there are sort of background risks for it. So we know that trauma and adverse child experiences particularly are like sort of smoking is to cardiovascular disease. They're a risk to persistent pain. Not inevitable that you're going to get it, but they're a risk that we should be mindful of. And also some personality traits, those sort of people pleasers, people who tend to try and put other people in front of them or be a perfectionist, tend to be a little bit more susceptible to this kind of overprotective pain. So this idea that actually kind of helping people to find evidence that they might have an overprotective brain can be really useful. And Leonard, I'm looking to Lee because I wanted to bring him in the discussion, but we might talk about ways that people can find evidence that suits them. What is it they can kind of tune into that goes, actually, do you know what? When I was watching that film, I didn't have any pain at all. How is that? How does that happen? Or when I was, listening to that kind of piece of music, I was much more relaxed. Actually, my pain went away for a bit. So looking for evidence can be a really great way of helping people to understand this overprotective brain concept. The other thing we can do with people, I think, is kind of get across this concept, and this is, I think, where I come into lifestyle medicine, that we can help people to grow their life box. And what commonly people say with living with pain is that pain, if you like, if pain is this orange squiggle and the grey bit is their life, pain takes up their whole life. It's like, there's no room around the pain to live at all. And in fact, often it feels to them like kind of the pain is causing the life almost to close in. It's like a sort of shrinking life. And they just sort of feel overwhelmed and sort of it's horrendous. So often the kind of the message to start off with in terms of pain management is that, look, a lot of the things we've got may not necessarily hit the pain straight away, but we know what we can do is help you to grow your life box. So whilst the pain may not change a great deal, we can actually help you to do the things that you want to do and make more space around the pain. And that's where some of the kind of approaches to dealing with your mental health, dealing with your sort of activity and movement, your relationships, and some of the kind of lifestyle things can have a real effect at initially helping people to grow their life box. We know actually from for following people through that this approach actually can lead to people, down regulating that overprotective brain and the pain reducing as well. But it's a great place to start. So this kind of concept that everything matters when it comes to the pain, we can't just focus on the pain. And I think that's where it brings me into the sort of lifestyle medicine approach, because I guess the narrative that we're trying to get across is that rather than necessarily, get rid of pain, be a pain blocker, analgesia, what we're actually trying to do is calm this overprotective brain. And there seem to be four great ways of doing that. So the first, you might be surprised, you may already know, is nutrition. We kind of know that, if your metabolic health is poor, if your brain is in a poor metabolic health context, it senses threat. It's almost like a social threat to the brain. But also, our foods can be pro-inflammatory, and they can also be anti-inflammatory, perhaps through the mediation of the microbiome. So there's a lot that we can do around attention to good metabolic health that helps to underpin good calming the overprotective brain. So that's something a real connection between lifestyle medicine and the pain system. The next, again, I'm sure you'll be well aware of, is sleep. It's almost ubiquitous. I don't think I've met anybody that suffers with pain that doesn't also have sleep problems. Is it the pain that causes the sleep problems, or is it the sleep problems that causes the pain? We don't entirely know, but we know that being strategic and helping people to work through the latest, kind of, top tips and sort of really pragmatic approaches to pain management, to sleep management, way beyond just sleep hygiene can be really good. Thinking about the behavioral science now and the kind of, pain CBT is some really good stuff there. As I've mentioned, previous memories, psychological inputs, your mood has a massive input on whether the brain decides to sense pain. So having great strategies to calm, relax, to perhaps deal with previous trauma, again, can be highly effective in calming this overprotective brain. And probably best to last, actually, which is kind of, again, really where I think kind of coaches and so on can come in, is that if your brain is stuck in this overprotective mode, the first thing it says to you is that it's not safe to move. Again, it's trying to be benevolent. Let's keep you still. Let's stop you damaging yourself. So consequently, actually teaching your brain that it's safe again to start moving and getting some gentle movements going can be a real game changer. So these kind of four areas can be massive. And for me, this is where coaching comes in. This is one of the reasons why I got into health coaching. In fact, I discovered coaching when I was in the pain clinic, because what I realized is that it wasn't the injections and the medications that was making the biggest impact. It was when people learn how to look after themselves. So they built their own sort of self-confidence. So Tim and I, working in the pain clinic, sort of thought, actually, if we're going to be really effective, we've got to get good at helping people to discover this. How do we build people's self-confidence and raise awareness of the body's trying to protect them, but it's not particularly helpful, and support their kind of like decisions in what they do in their life. And that we discovered as coaching, which is why Tim and I ended up setting up Peak Health Coaching. So coaching can be really useful. I think as healthcare professionals as well, we can serve a role in terms of the medication reviews. And I'm going to just very briefly touch on those in a second. Don't worry, I will stop talking in a minute. But increasingly, I think, the kind of the group work that happens in pain cafes, where you can get peers together and you can generate sort of hope and camaraderie. And I put that, give people an opportunity to give back. What I've learned across my health career is one of the most powerful things that gives that sense of coherence that Antonovsky talked about is a feeling that you're able to give back to life rather than always take, 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 take. Not your own fault. You just feel that way because you feel, not able to contribute. But actually, you start to be able to give back. That's actually a really powerful enabler for sense of coherence. Um, and we do probably need education as well. And I'll talk a little bit about that. So I wanted to mention health coaches that are being provided. So we know across primary care networks, we're taking on health coaches. We're teaching them how to support people with chronic pain. This group, Pure Physios, we've been working with a little bit recently. They've been training they've a really lovely sort of approach to supplying health coaches that are already trained in pain management, and they've been having a massive impact, reducing the pain self-efficacy questionnaire score from 28, increasing it from 28 to 44 on average. Take it from me, that's a massive change. That's a real game changer. And also leading to sort of like real big changes in use of medication and GP visits. So we're getting emerging evidence of how health coaching is really supporting this pain management approach. Um, Very quickly about medicines, we always used to sort of think that medicines were useful, and they are useful for the biological bit, and maybe a little bit useful for suppressing that central sensitization of the brain. But you dampen down the brain, you dampen down everything else, so people get tired and don't have much energy and brain fog. And of course, what medicines don't do, they can't hit the boxing gloves. There's no medicines that really affect that overprotection bit. So medicines, not surprisingly, are often not the answer. So when we're working with medicines, and we do this on our courses, which I'll talk finally about in a second, we take people through where you can use good prescribing. And one top tip for you that I want you to take away that I've learned is that all the evidence now is moving away from slow release medication. So I used to, when working in the pain clinic 5 years ago, even, we used to prescribe slow release background. That's really gone out. We've realized that's led to high volumes of medication over a long period of time. And what works much better is to give people short-acting opiates and encourage them to only use them for flare-ups and then pull back. It's a much better strategy for people in the long run. And of course, identify and treat neuropathic pain, as I said before, and parallel, mental health issues. So there can be some benefit in that. But mostly what we're doing now is trying to de-prescribe if we possibly can. And the narrative I often use here is that to start off with is around, what if we could reduce some of your medication so you had less side effects, were able to grow your life box because you've got less things holding you back, and we didn't make a great deal of difference to your pain? Would that be an advantage to you? We'll do it slowly, we'll do it together, but we'll help you out with it. And alongside that, I'm often apologizing that actually we know why most people have ended up on medication. It's partly to do with, well, mostly to do with the medical profession. We thought it was the right thing to do, but I'm afraid as time's moved on, we've realized it hasn't really ended very well for people. So when we're deprescribing, it's often a steady, careful partnership work to reduce doses over time. And what's really key is that you connect people up with alternatives. So the things I've talked about before, and we can perhaps delve into a little bit when we chat. I'll go with that. There's some good resources. I think we're going to send around these slides afterwards. These two resources there, that deprescribing guide from Knots is great, and then a little bit around why medications are not good in the long run there. So if I think I probably make this my final slide. Actually, it's good to get talking. So if I was going to redraw that overprotected brain with the boxing gloves, what would I have? I would have it having jazz hands, keeping a bit of movement going, balancing things out, accepting there'll be good days and bad days, and actually that pain is probably a friend to me. It's good. So there would be a compassionate heart in the middle that says pain's actually a friend to me. And I got that off Lee again, to guide me when I'm not looking after myself. So perhaps pain is there to warn us that we're maybe not noticing enough about our environment or previous warning signals, and that we should pay a bit more attention. And I would have it propped up with really good metabolic health. I'm gonna come back to that. I'm gonna stop there and just open to questions. If we run out of things to talk about, I'll do those last two slides. But let me just stop sharing there and see if there's questions. And when we deal with the questions, I might invite Lee to come in as well, because Lee is a patient with years of lived experience that I currently work with at Peak Health Coaching. We partner together in delivering training because we believe that lived experience alongside some clinical expertise is a winning combination. So let me stop there and open to the floor. I don't know how you want to do this, Caroline, whether you want to encourage people to put questions in the chat box. I haven't been looking. I don't know if there's any questions there. There's loads of places I could go. I've just peppered a few ideas out there, so I'm really happy to dive down a little bit more onto how the lifestyle factors might work. Or I'm very happy to talk about the training that Peak Health Coaching do and how we build that kind of collaborative approach to building health coaching and the kind of lifestyle non-medical approaches alongside how we try and teach people who are in those prescribing roles how they can kind of like work alongside and safely de-prescribe and kind of hold a really consistent medical message.
Ollie,
Mm.
how do you hook people in? What's the hook? Because there's always the what stage they're at to engage with that change, isn't there? So I can imagine some patients would be at that point, and I can see how that would work with a bit of practice, finding finding their own journey with it. But how do you hook the other people in, or do you just mention it like you do with smoking, say, okay, come back when you're ready?
Yeah, I must admit, and again, I'm going to bring Lee in on this one in a second, but for me, this is where the coaching style approach to medicine's really helped me, because I do try and, in my own mind, sort of assess where somebody is in terms of what we might call their activation. So some people you can tell are kind of like super activated and they just need a little bit of guidance, a little bit of advice, perhaps connection with some right resources. And in some ways, they're quite easy, aren't they? The other end of the scale, which I think you're driving at, is those people where they're perhaps highly distressed, overwhelmed with life, don't see that they've got any agency in what they're doing or any role to play. And my approach then is quite different. Even though I know I've got loads of stuff up my sleeve, I really don't just try and bombard them with it. I try and make my role to kind of meet them where they're at, find out what's going on, understand their situation, their context, and in doing that, that builds rapport and connection. Sometimes I'll try a two appointment approach. So I'll say, look, do you mind? This is obviously really complicated. Can we have two appointments here? And the first appointment, I'm just going to listen to you and hear everything that's going on for you. And I'll often say, tell me your pain story. We've got 15 minutes, 10 minutes, whatever it is. Tell me your pain story, where it started, how it's progressed, and how it is now in the time that we've got. And then I'm going to have a think about it, bring you back, and then we're going to think about what might be the first steps for you. So that can work. The other thing I would say is that I'll often try and get to the point where a killer question for me is your life working for you at the moment? Do you know what I mean? And if we can get to the point of enough trust where patients will say, my life really isn't working, it kind of leads into well, something's got to be done, isn't it? And if we can do that together and kind of get to a point where we're prepared to work on it with joint responsibility, then you've got a kind of platform to start with, if you like, really. But that's my initial response. I know Lee is a patient. Do you want to come in and, where do we start with people living with persistent pain?
We listen to them. Ollie's sort of spoke of my past a little bit, but 3 decades of living with persistent pain, accumulating in 2021, I've been on 28 tablets a day in a horrendous place in life. But, my pain was never there to be seen. But, a little bit of time, we talk about health coaching and those multi-appointment approaches, it was always there to be heard. It was always there to be heard in terms of ACEs and childhood trauma. And I appreciate the system doesn't particularly accommodate time at the moment, but it's listening to the person and allowing them to share that story because it often comes out in that story for what I understand. But I also think what worked for me was the two words of curiosity and hope. And Ollie spoke about encouraging people to explore their pain. We know with persistent pain, it fluctuates. Some days it's high, some days it's low. Well, how does that work? What are you doing when it's high? What are you doing when it's low? We have a lady that comes to one of our classes that lives with complex regional pain syndrome, and she explains a good day as 9 out of 10 pain. Imagine what that must feel like. 9 out of 10 pain is a good day. And she comes to our warm water aquatic session, and I say, why do you come to this session? Does it take your pain away? She says, no, but it's just not important when I'm in the water. And we explore these kind of avenues of curiosity and hope. And I think the thing is you aren't going to catch us all. I know we're your favorite patients. You love us to pieces. I know you do. We're the cream of the crop for you all. No, no, tongue in cheek, we're not. But we can't catch everybody. But the saying I often use is, when we plant seeds, they don't germinate straight away. But that's no reason to stop planting seeds. And we've seen so much evidence in our workshops of people refusing and saying, no, no, no. And within 3 weeks, we had a guy come back and said he found something that took away his pain. It wasn't opioids, it wasn't gabapentoids, wasn't morphine. It was watching Peter Kay. Yeah.
Peter Kay.
It's crazy, isn't it? Solutions can be so simple.
Yeah.
Brilliant. Thanks, Lee. There's some hands up I can see. So it's good to bring in some hands. Basiliki and then Rosita.
Thank you, Ollie. That was a really interesting, actually, talk. Thank you very much for that. I suppose that my question was, I deal with obesity and weight management, and the biggest hurdle sometimes is social stigma and social perceptions. What do you think is being done in that regard? Once society understands that painkillers are not the panacea for pain relief, then I anticipate you might be a step closer. But how is that being addressed, do you think, and how should it be addressed? What are your views on that?
Yeah, I mean, stigma is a really big thing, isn't it, when it comes to obesity, mental health, pain as well. And I think we're often, the two things I hear is that people sort of like, because you haven't got anything to see, people don't believe you. So people are always having to sort of like create this kind of like, justification that they've got pain because they feel like they're not believed, and perhaps worse still, that people think you're being a malingerer and you're making it up and it's all in your head. And some of these explanations you've got to be really careful about, because an oversensitized brain can sound a bit like you've been a bit pathetic, and actually you've just you've just let life get on top of you, haven't you? So I think the best way to reduce stigma is for us to kind of like be really clear about the understanding of what's going on with pain, and this fact that it's a protective mechanism that's become oversensitive. It's not someone's fault. It can happen to any of us. In fact, it happens to most of us actually at some point in life. But that we've got to get better at understanding the root cause so we can offer really good treatments. And that moves us away from medication and analgesics towards things that will calm the overprotective brain. And we could come back. I'm going to show you at the end some resources that I think are really good, because I've had to rattle through this today. We normally take 2.5 days to teach people the content of what I've rattled through. Is that useful? Brilliant. And then Louise.
Hi, thank you. Really interesting talk. I was just going to ask about you sort of deprescribing and that cohort of patients where they do seem to have a very sort of fixed belief that medication is their only answer. So in those patients where, that's their thoughts, do you tend to keep them on what they're on and then work on sort of improving their life box and doing all the other things and then deprescribe? Or is that something you try and tackle very early on in the process?
Yeah, I mean, deprescribing is really interesting, isn't it? I think there's a few things. I think first of all, we've got to recognize that it was mostly our fault. For a long time, the medical profession pushed medication as the solution to persistent pain. So it's no wonder that people have got it in their heads that it's the thing that they need to help them. So I think there's a lot of rapport we can build by kind of meeting that and saying, look, it's as much our fault as it might be, the situation you find yourself in. Then if you think about that overprotective brain, almost if you perceive, wrongly or rightly, that this is the only thing anyone's doing for you, and then someone suddenly steams in and goes, oh, sorry, we've changed our mind, we're going to take away your medicine now. The overprotective brain is going to go into overdrive. Do you know what I mean? And whether or not it does make the pain worse, it will do, because they perceive it that way. So the most important thing is to help people understand, and I think when the narrative around that, it may well be that if we gradually experiment with reducing your painkillers, your pain actually won't get any worse. And in fact, we know that opiates, have a hyperalgesic effect. So actually it might make your pain a bit better in the long run. And it almost certainly will reduce some of the side effects you've got. Are you willing to give it a go with me together? I think that's a really different narrative. And particularly if you can couple it with, and actually, we've also got some health coaches that understand a whole lot of other things that we now realize are much more effective than medications. For me, that's a much stronger offer than just saying, SARS, nice, change their mind, opiates are no good anymore. And even though that is right, the way you go about it is so important. It's a bit like a comedian, isn't it? It's the way you tell the joke that really matters, not the content of the joke.
Yeah.
Yeah.
Thank you.
Let's keep
Thank
going.
you.
Great question. Louise, I think, was next, wasn't, and then Bridget.
Hi, thanks, Ollie. Can you hear me okay?
Yeah, brilliant.
Thank you ever so much. I've already put some, as we had a little bit of chat on the WhatsApp. So I'm a GP, but a breathing practitioner as well. And so much of what your talk was saying absolutely resonates. The one, and obviously, as you say, sleep is so important. And the one thing that I don't think we talk about enough in the chronic pain circles is how people breathe when they're asleep. You've already mentioned, obviously, the oversensitive nervous system. So when we're asleep, our sympathetic drive should go down, our body should feel safe, and our body can then repair and recover. But if someone is sleeping with their mouth open, they're snoring, they've got obstructive sleep apnea, they stop breathing, essentially their body maintains the sympathetic drive when asleep, and fuels that oversensitive nervous system. And obviously, like you say, it's a bit, it's a chicken and egg, isn't it? Because it may have been their adverse childhood event or whatever has perhaps sensitized their oversensitive nervous system. Is it that's caused them to breathe differently, which has then caused the sleep disorder breathing? Or is it the other way around, that they had sleep disorder breathing that was undiagnosed, and then that's what's generated the chronic pain? One study I've seen with fibromyalgia patients, 66% had obstructive sleep apnea when they looked at them. So, and what we forget is opioids, gabapentinoids, benzodiazepines, they're all respiratory depressants. So you could actually cause sleep disorder breathing with them, or if someone's got it undiagnosed, you're making it worse. And then the other thing I've been reading, I don't know if you've read much about sort of fascia in the body. So that's that sort of very mesh-like structure that's in the musculoskeletal system. And what I find really interesting, there's one paper that said this interoceptors in the fascia, which gives us a sense of the physiological state of our body. And one of the sensations of interoception is air hunger. And people, if they're not breathing well, they sense air hunger. And it's so interesting. I don't know if you've read the Body Keeps the Score by Bessel, what's it called? Bessel van der Kolk.
Van der Kolk, I've got it on my shelf. Yeah.
I mean, I'm only like a third of the way through at the moment, and I just resonate with so much that, exactly.
Yeah.
And essentially, if someone's stuck in that past trauma, they're breathing differently. And then if they're not breathing well at night, so we're going to publish it. Hopefully, we've applied to publish it. We ran a chronic pain program at work, combining yoga with a breathing re-education program that I ran, and we got 30% reduced or stopped their opioids and gabapentinoids. So I just think, have you asked many patients, do they snore? Do they stop breathing during sleep? What's your experience with that? Because all of my group didn't breathe well.
Probably not as much as you do, Louise, and I love the stuff you're putting on the WhatsApp group, because you're really shining a light on it. And I think what I'm thinking when you're saying that is that there's so many modalities that we have to keep in our mind. But the other thing I would just kind of counsel the group around, really, that I've learned is that the danger for all of us is that we've got so much expertise now, but the risk of that is it puts us in control and diminishes the patient's control. So the skill for me is being aware of all these things, the microbiome, the diet, the how we get people to gradually move again, thinking about their breathing, thinking about how they relax, and thinking about past trauma, all these things that we're becoming aware of. But how do we start to encourage people to consider that for themselves and to find the evidence for which of the bits they think will be contributing to it, but in a way that keeps them in control? Because the more we have the ideas and the more we say, I know what you should do, oh, you should do this, oh, you should do that, we might have the right answers in the end, but the way we go about it is we still undermine their control. And ultimately, the sense of control that someone has is more important than the order that we find the answers. So it's just, that's a dilemma for us, is we know this stuff, we've read the papers, but how do we keep it in that thing? So it's just a challenge, a real challenge. Great point though. I'm going to keep going with Bridget next. Thank you, Louise.
Hi, thank you. That's really interesting. I've recently just joined, Caroline got me into the North East group. I live in Newcastle. I'm a GP, but I've actually recently left my practice and I'm now doing locums in various rural Scottish practices. And the first thing I would say is it's really been interesting as someone who just comes in, sees people never seen before, the number of people who are presenting with persistent pain, persistent symptoms, but presenting with other things, sort of, which they are presenting with, rather than coming and saying, I've got this persistent problem. And it's dark how, talking about that, it's going to be the biggest chronic disease. It is absolutely, I would say it's 50% of everybody I see really needs a conversation about persistent pain and persistent symptoms. And the second thing is I was involved in a trial or project with Chris Burden from Sheffield. It was really about persistent symptoms, but a lot of that was pain. And it was about, can we teach GPs the skills? And so we ran clinics. And I would absolutely say time and listening, all those people I saw, given, I have to say, half an hour, 45 minutes, they would lead themselves into that understanding of, this is where my pain started. What were you doing with the pain? I mean, I was speaking to somebody today who'd come in, who essentially, I think, has fibromyalgia. I said, well, how long was the pain? Well, it started in my 40s. Of course, that was when I had my terrible divorce, and they just come out with it themselves. And if you just allow them, and about the control, they will see that themselves. So I'm a massive believer in it. All boils down to letting people tell their story. And I once heard something from Tim talking, and he was the one who began that in my head about telling the story. So those are sort of affirmative comments. My other challenge is, what do we do? And you're preaching to the converted here. What do we do to all these specialists who are determined to investigate and do stuff and push people further and further along belief that something can be done? And by the time they come to us, there's so much to unravel, and there's so much drug that's been given. And how do we really get this message out to the medical professionals? Because that is the thing. There's a girl I saw today, 23, who's got chronic pelvic bladder pain. She's been seen by some local urologists who've done urethral dilatations and this and that, and they're now talking about, a transverse nerve stimulator. She obviously, again, listen to her. She has lived through her parents' horrific marital breakdown and domestic violence, blah, blah, blah. And yet she's now so fascinated and hooked on something's got to be done when I go to the next clinic, and they're going to try and find something. And the professionals who are sort of pushing their specialism and their belief that they've got the answer and there's something medical and we'll give you more drugs and we'll give you this, I find that's really against lifestyle medicine as a whole. And so I guess my challenge is, how are we going to educate all these people? There's a lot of people out there who aren't in this group and aren't on this path. And what are we going to do? I'll leave it there.
It's a great challenge to the group, isn't it, Bridget? And, it's interesting to hear you say that. I mean, one of the armies that we've got that I've seen is that increasingly there are people with lived experience of chronic pain who are very willing to help us. And it's very powerful hearing from someone who's managed to learn for themselves. And I think the big transition for us as the healthcare system is, we've been very stuck in the biological model, haven't we? Do you know what I mean? And we have to do that. Absolutely. If I got, a cancer diagnosis, I would absolutely want chemotherapy, and I'd want the latest, when my OA of my hip gets bad enough, I'll probably want a hip replacement. Do you know what I mean? But what we're not very good at is, I think, the kind of like the non-biological stuff, that's social stuff. And if we can become good at proactively diagnosing, I'm calling it the overprotective brain just because to make it easier to talk about. But we can red flag and screen for biological stuff and say, actually, look, all the signs are proactively showing us that you're probably got pain predominantly because of the way the brain's got overprotective. That's not your fault, but nevertheless, it is the diagnosis I can make, which means the treatment strategy is really different to what we might have done before. But now we've got a viable treatment alternative. We've got health coaches that have got time and understand how to talk about it and understand how to get people eating well and moving well and thinking well and managing stress. So we've got a viable alternative to go with our alternative diagnosis. And I think that's what we've got to push on, Bridget. And I don't know. I'd love to hear, what do you think? How are we going to do it? You got any ideas? And then we'll come to the other hands.
It's really difficult. I think, again, it's a bit like that push-pull. If we can get the population at large to believe more in that and be more keen to know about what they can do for themselves and how they can go against it. I think it's sad in a way that all these additional roles that we've had, which involve things like health coaches and counsellors and social prescribers, a lot of the medical profession is decrying, saying we just need more GPs. But I feel we don't need more GPs because they're just going to more medicalise and biologicalise things. So there's a sort of real tussle within the medical profession, I think. And I don't have the answer. Like, it upsets me every day, Ollie. So I don't know what the answer is. That's why I'm saying, what can we do? But
yeah, well, I think you're amongst. I mean, the thing is, stay in touch with groups like this, because what I see amongst this is people that really get it. So I think that helps, doesn't it? Let's come to Rob, because I think you had your hand up, Rob, and then Caroline.
Hi, Ollie. Can you hear me okay?
Yeah, absolutely.
Right.
Nice to see you,
Those
Rob.
who don't know, I'm a bit like Ollie. I'm in Sheffield as well. I'm a GP working in a pretty socially deprived part of the city, and pain is a daily, well, sorry, multiple times a day presentation. I find these patients actually really fascinating, and actually find them really interesting and rewarding, because actually in the past I would have been a little bit daunted by somebody saying, "Oh, everything hurts all the time, and I can't move, and I'm just tired, and give me some sleeping pills, I'm still tired." And now the approach is very much, "That's really interesting. I wonder why your body's giving you that message. What's it trying to protect you from? What's it trying to help you with? Or what? There must be a reason for that. Tell me about, what's the most pain you've ever had in your entire life? Can you tell me when?" And we usually go back to their childhood, and we can make a story that makes sense. It doesn't necessarily mean they're fixed. The challenge is, of course, that takes time. And as Lee mentioned, feeling heard and understood is transformative. It absolutely is. And I give people a story that at least makes sense, even if it's not an immediate fix. Because this happened, you've adapted in this way, because when you were 6 years old, it makes perfect sense to, hide yourself away or to wrap yourself in cotton wool, because that's not such a good thing. But maybe when you're 36, it isn't. The question I was sort of getting to was, a lot of my patients have been messed up by Pain Clinic, because Pain Clinic has scanned their body or injected them, or just decided that some kind of opioid patch or some other tablet is possibly the answer. And I'm beginning to I know you've been there, Ollie, like physically being there. I can't quite see the point, because actually the thing that heals my patients seems to be relationships, and actually having not a remote service that they go and visit a couple of times and that's it, but they actually have somebody they get to know, and it could be a GP, but it could be somebody else that they trust. It should be the GP at the beginning, because I think sometimes you need somebody to say it's not this, and I think then they can take that on board, and then you can then utilize other people. I think if you try and introduce the touchy-feely sounding stuff a bit too soon, they sometimes feel you haven't taken them seriously enough. So I think sometimes the GP is important at the beginning to say, "I've heard everything. We've done all these tests. We don't need to do any more." But we had a very interesting discussion at our locality council about opioid deprescribing and the pros and cons of a specialist pain clinic, which just seems to focus on regional parts of the body and single organs. I don't know what you think, Ollie, but I'm kind of thinking, would we be better off redirecting those funds to communities?
I think that's the conclusion you've come to, Rob, isn't it? And I think as a CD of a PCN, I've always been keen that pain management is in the community. And I think over the last few years, seeing how effective things like pain cafes are and peer support and health coaching, it's really cemented it for me. In fact, if you forgive me, I wanted to just go back to just a couple of final slides. Is that okay, Caroline? I can see.
Yeah.
And I'm very happy to stay on and take questions, but I'm just aware that we might be coming to the end of. Well, we've probably just gone.
Yeah, no, that's fine. I put my hand up, so I could just say that we are getting towards the end. But if anyone needs to drop off, that's fine. But I'll let Ollie do your last
Yeah,
couple of slides and then we'll.
you're very welcome to shop off and stay. But I could keep talking forever, and I'm conscious there's so much also that people like Lee can say that I haven't really brought in. But let me just go back because I think this is a story that really had impact for me. And I'm sorry, forgive the picture, probably not right, but we were reviewing our pain cafe, which Lee and I have been running in our network for the last 6 months. And we got the patients have been coming along to just kind of tell us what had happened as a consequence of being at the cafe. And we heard all sorts of stories, really positive. But this one really stuck in my head. So a young woman who had pain for she's in her mid-30s, had pain for 2 decades. So crazy, isn't it? And she came along and she initially, when we said recovery is possible, she almost got out and left the room because she was really thought that there was nothing that could be done. She had chronic pain and ME. And so, but at the end of this thing, she was reviewing, she was saying, you know what, I really didn't think it did, but these six pain cafe sessions I've come to where we've mostly talked, we've done a little bit of education, we focus in a little bit around why, this story about it being the pain being protective. And we sort of asked her, well, what's it happened? Well, she said, well, the thing that's happened to me just recently is that I got this resurgence of pain in my jaw, and I used to get that a lot. She said a really bad bout of it a few years back, and I went to the GP, and they described that they thought I got mastitis. They gave me antibiotics, and I had a real medical treatment. And at the time, I was in a kind of fairly sort of toxic relationship, and she said, it had gone away, and she said, but actually, I saw that person again. Came back in contact with them, and the jaw pain came back. And she said, as a result of coming to the pain clinic and understanding what's going on, I said to myself, I just wonder if this jaw pain actually is a result of seeing that person again. And what it's doing is it's kind of resensitizing my brain. And she said, what I normally would have done was rush back to the GP and gone, oh, my jaw pain's come back. I need more antibiotics. She said, I didn't. I just thought, I just wonder what happens. What if I just tell myself this is related to seeing that person again, stop seeing them, just gave a bit of time. And she said it settled down by itself. And that was so powerful for her. She said, I've learned a new strategy for how to deal with my pain that doesn't involve going to the doctors, that is myself. And she was so pleased with herself. And then she finished and then she said, oh, and there's another thing as well. I've stopped my duloxetine. I just decided that I didn't really need it. She goes, it was a bit tricky. And I have a little bit of resurgence of my pain, but I feel so much better being in control. And actually, I can see the light at the end of the tunnel, and it's settling down. And so it was for me, it was really that sort of story just shows me what we can do really. And so I wanted to show two last slides just around some of the resources that I think are really useful. If you want to take a screenshot of this, we'll send the slides, I think, afterwards. So I mentioned Pure Physiotherapy. They've got some lovely new resources in there. As I say, they're putting out really excellent health coaches that are fully trained in pain management, if that's a line that you want to go down. Alternatively, of course, you can train your own health coaches. Pete Moore's Pain Toolkit, been around for ages, got some great stuff in there. Deepak Ravindra's Pain-Free Mindset book, brilliant, really covers loads of the lifestyle medicine stuff. Frances Cole and Emma's Live Well with Pain, they do the Footsteps Festival. They've got the 10 Footsteps to pain management, really user-friendly for patients. The Curable app, I've never really been too fond of digital stuff for chronic things, but it's a great way of helping people understand and challenge some of the messages. And there's some really usable tools on there. Lee's Partner in Pain Facebook page. I don't know, Lee, do you want to just say 30 seconds to that?
30 seconds, that's a tough one for me.
Sorry, because I know we're coming to the end.
I came out of the pain management program, and I'm wondering, just listening to Rob, there must be multi programs in Sheffield, because mine was great, and it was no biomedical. But I came out of that program after 9 weeks, and they were saying to me, "This is it. There's nothing else." But I wanted more. I realized my pain was going away just simply by being around 14 people that lived with pain. That's where the curiosity came. So I very selfishly set up a Facebook group for the people in that cohort to join, which 3 did, and then 3 friends did. That now sits at nearly 470 people in 2 years. And about 25% of the membership are healthcare professionals, GPs, physiotherapists, pharmacists, health coaches, link workers, and they exist in this group to learn from how we talk and the way we lead things. And in this group, you've got probably the UK's leading pain advocates in Sean Jennings, Louise Trewern, Nikki Jones, Fiona Symington, myself, and a couple of others. And we lead with positivity, we lead with positive stories. And it's almost like people don't post negative stuff because it's not the norm. And we drive this positive force, this positive angle. And it's really evolving into a great, safe, private educational space online. And we also have a website coming out in about 2 weeks, which is fully funded by Sport England as well.
It's brilliantly, thank you. And
Thank you.
you're very positive in the way you do it, and there's lots of hope, but also you acknowledge the tough side. And I've seen stories on there of when people just, say, have you ever felt like this? And it's just really reinforcing for people to feel like they're not alone. I think it's a fantastic resource, and I would encourage everybody to join that Facebook group. And then the last thing, that Tame the Beast video down there, it's a lovely 5-minute explanation of that overprotective brain concept. Brilliant for healthcare professionals and for patients that have got enough activation to be ready for it. But I would encourage you to have a look at that. And the last slide I'm going to show, forgive me, this is, I guess, a bit of a plug. We do, as Peak Health Coaching, run training courses in a coaching approach to pain management, and we there, if you look at our website peakhealthcoaching.com, you can see details. But what we do is we have 2 half days for people. So there's a generic half day that we encourage everybody to come through. So GPs, pharmacists, health coaches, link workers, expert patients, practice managers, whatever. So you understand how to explain pain, what the latest pain science is, and we go into it in a lot more detail than I've rushed through today. And then we encourage people to come back for 2 different second half days. One specifically aimed for prescribers, how to prescribe well and how to deprescribe well in the context of this overprotective brain, a little bit around some coaching skills. And then for those that are perhaps hopefully already have some coaching skills, but are going to be more involved in the non-prescribing aspect. It might be your practice nurses, it might be your health coaches, link workers, care coordinators, or indeed your expert patients like Lee, and they would come to learn more about the non-medical aspects. And then we encourage people to get back together and work as a team, because actually, as far as I'm concerned, good pain management is a team approach where our main focus is to build the confidence and locus of control for the person living with pain. And we all have to do that together in everything that we do.